Hello guys, welcome back. This is Dr. Anjit again, your pathology educator at Unacademy. So here we are with one more case of pathology nuggets, the case number 9. If you are a pathology postgraduate and if this is the first video you're seeing, please go back to the channel link, and you can see lots of pathology nuggets. All of them are case discussion for postgraduates, and it'll definitely help you. We are discussing cases. Hopefully we'll do every day one or two, and we'll cover lots of cases so that for a fast revision during your final year post graduation, before your viva or your slide conferences, this might help you. Fine. And there are classes specialized for postgraduates in the Unacademy app, and all of them are special classes. You can attend it live, we can interact together, we can learn together. If at all you miss them, you can see the offline recorded version as well, and you can download all the images which I share. We can use it for later references as well, and as I said that all of them are free of cost, right? So without any delay, we shall go to the next pathology nugget, the pathology nugget 9. And it's a bit of a difficult case. Let's see if we can crack it. Right? It's a 50-year-old person with a biopsy from the bladder. I am purposefully hiding an history here, which I'll tell you later on. Right? So this is the first image. This was a biopsy which we got from the bladder. Like what we saw was this. When you look at the biopsy, first impression for me is there are lots of hematolymphoid cells. That's all. Maybe I'm seeing a few cells. I'll use a yellow color ink. I'm not sure what these are. They're a little bit bigger, but definitely one impression is it doesn't at least look epithelial, because when I'm having a bladder lesion, first thing comes for me is my urothelial cancer malignancy. And urothelial malignancy is very classical. You'll have mostly a papillomatous lesion, a thick lining epithelium, and lots of mitosis and very ugly looking cells. So what I see here is lots of inflammatory infiltrates and lymphoplasmatic infiltrates. You have few blood vessels here and there, reactive stromal tissue, and few cells which I'm not sure what they are. Let's go ahead and look at the next image and see if I'm able to get some hang out of it, right? Again, this image also shows almost the same thing. Yeah, I do have a little bit of fibrous lesion tissue here. Again, the predominant one is you can see these cells, right? There are a few little bit large cells here and there, which makes me think, is it really a neoplasm? If it's a neoplasm, it is definitely not epithelial. Is it a stromal neoplasm? That doesn't look spindle as well. So my first bet, if it is a neoplasm, it could be an hematolymphoid neoplasm. I'm just thinking about it because whatever we saw in these two images, what I'm having is lots of tumor lymphocytes, your hematolymphoid cells, and few large cells here and there, right? Let's go ahead. Okay, this is something again mind-boggling, right? I'm sure you must have picked this image. I do have amazing well-formed, almost a good formed granuloma here in the background of the stromal lesion. So I see a granulomatous lesion here, plus I'm seeing hematolymphoid structure here. Again, still even after 3 slides, I'm contemplating whether it's an inflammatory lesion or a neoplastic lesion. Again, if it's neoplastic, I'm going to think of an hematolymphoid malignancy, right? We'll go and look at one more image as well. Same thing, there's not much of a difference here. Most of hematolymphoid cells. I do have few large cells here and there, few smudge nuclei here and there, but predominant of them are hematolymphoid cells. This image is going to be very much diagnostic. In one field, what you saw was it almost classically looks like a lymph node, right? The background population of my hematolymphoid cells and amazingly large cells with clear nuclei. If I have to target this cell alone, I'm just going to highlight this cell alone. If this is a lymph node, this one, see now definitely it's malignant. I'm having lots of large cells, which is unlikely for an inflammatory lesion. I have large cells in the background of inflammation, plus also had granuloma. So I'm going to think in favor of one Hodgkin's lymphoma, right? Hodgkin's lymphoma and bladder is extremely unlikely. So I'm going to give you information here. What information was there is the patient was a recipient of an renal transplant. So we do have a group of disorder in WHO in the hematolymphoid structures and post-transplant lymphoproliferative disorder. Hodgkin's can be one of them. If it is Hodgkin's, I'm not saying it is Hodgkin's. If it is Hodgkin's, it could be a post-transplant classical Hodgkin's lymphoma. And if you have to name these cells, they look like an RS cell, right? We have multiple variants of RS cell. Which variant it will fit into? Perfect, it will fit into a lacunar variant, right? Like the nodula sclerosis, it will fit into a lacunar variant. And yes, Hodgkin's can have granulomas. Sometimes of an FNAC, the granuloma will be the only thing which you can pick up on a Hodgkin's lymphoma note, right? So don't forget, if you see granuloma, first possibility is always tuberculosis. If it is a malignancy-like condition, think of an Hodgkin's lymphoma, right? So we went ahead with markers. This is not the first panel of markers I'm going to show. We did many markers and we finally narrowed down to Hodgkin's lymphoma. It is a difficult case, right? This is the first one. Here, I'm not sure what marker it is. I think it's either CD15 or CD30, right? But definitely it is positive in the large cells. These are my large appearing cells. In the background, you can see multiple negative things. All of them are small lymphocytes, right? I think this is CD15. And this is exact CD30. Same replica. So CD15 is positive, CD30 is positive. So I'm comfortable in calling it an Hodgkin's lymphoma, right? There is one marker which I want you to be concentrating very much on, because sometimes CD15 and CD30, when a technician and not much of an experienced technician does, it goofs up. It's not a marker which can be easily done on a biopsy. So always keep a backup. I prefer the backup as this marker. This is your PAX5. PAX5 doesn't goof up. PAX5 is generally, if it's done properly with care, it comes well. Sometimes CD15 and CD20, even if the steps are done properly, it might not come up out well. That's the nature of the antibody. So rely on PAX5. So whenever you are working out in your college, hospital, wherever you are doing, I want you to apply PAX5 for every Hodgkin's lymphoma. Though it is not essential for me for diagnosis, I can diagnose with confidence with 15 and 30. I want you to apply. Because once you apply, you start seeing PAX5, you get used to PAX5. Otherwise, for a rare case alone, I can't use PAX5. So do PAX5, and PAX5 will be contrast. All these small cells are positive, right? They are darkly positive. That's how PAX5 will be. PAX5 is generally a B cell marker. So it will be positive in every small B lymphocytes here. And you look at these cells, where you have a faint positivity, right? The bigger cells are not strongly positive as compared to my lymphocytes you are seeing in the lower bottom of the field. That's how PAX5 will look. In a classical Hodgkin's lymphoma, the RS cells will be weakly positive for PAX5, like this image. I want you to get used to this, because as I said, one fine day I cannot go and interpret PAX5. Okay, this is how PAX5 will look, right? It's always based on my experience. You keep seeing PAX5 for long. In some difficult case, when my 15 and 30 doesn't help me, doesn't come out well, PAX5 will help me, right? It should be weakly positive in RS cells, and for I have a control here itself, very strongly positive in B cells, right? So this case was signed out as an Hodgkin's lymphoma, nodulus clausus varians of a bladder, your urinary bladder, most likely to an post-transplant lymphoproliferative disorder, right? This alone can come as an essay question in your pathology final year post-graduation, right? So post-transplant lymphoproliferative disorder is a consequence of immunosuppression. So it could be a patient who's on a bone marrow transplant or any transplant, maybe due to can be due to any other immunosuppression, right? I give a patient immunosuppression in order to prevent the organ rejection. So as a side effect of this guy becomes extremely notorious, fine. Most likely it's EBV positive. Most of the post-transplant lymphoproliferative disorder, PTLDs, are EBV driven neoplasms. So EBV negative proliferations are less here, which means I might not see an NLPHL in a post-transplant lymphoproliferative disorder because it is not EBV driven, right? So most of the EBV driven malignancy which happens in a post-transplant patient, I can categorize them as PTLD. As an entire list of PTLD. I'm just going to show you the table of what PTLD, how it is classified as per the region WHO. You can have a non-destructive PTLD, a polymorphic PTLD, monomorphic in the sense neoplastic, and your classical Hodgkin's lymphoma, right? So any patient you are having a post-transplant done and some lymphadenopathy comes, if it's plasma cell hyperplasia, just don't report plasma cell hyperplasia, report plasma cell hyperplasia query due to PTLD. Because I am making them go to an etiology, because I'm making sure the transplant surgeon or the team knows that this patient is having some problem with the immunity because EBV has come inside, which means if it is progressed for a longer term, this EBV non-destructive, just a reactive proliferation might become neoplastic, right? You can have infectious mononucleosis, just a fraud hyperplasia. This is important to name them as PTLD because this might, I'm not saying always, might become a plasmacytoma or any EBV positive neoplasm. Polymorphic, again, it's a reactive population, which I can tell easily with the help of an immunohistochemistry. Then I have monomorphic PTLD. This monomorphic PTLD can be both B cell as well as T cell neoplasms. There's no difference in the diagnostic criteria of DLB cell secondary to post-transplant and a normal classical de novo DLBCL, right? Same diagnostic criteria. Only one thing is the marker profile of EBV is very specific in PTLD. If you're listening to this and if you're postgraduate student, there is EBV based on eBarish and my LMP1 have different types of EBV possibility, right? I want you to read that and comment here so that we can learn more based on that, fine? And the next is in classical Hodgkin's lymphoma, again, which are also maybe more commonly associated than PTLD, right? So PTLD are EBV associated lesions, okay? Can be non-destructive, reactive, and a monomorphic PTLD, fine? So if your question comes on PTLD, I want you to have a brief introduction written based on your immunosuppression, then the pathogens of EBV, how an EBV enters a B cell via the CD21 or the CR2 receptor, then how it causes a proliferation, it kickstarts my nuclear factor K beta and got lots of proliferation. So you can have polymorphic or a reactive lesion as well. Due to the n number of proliferation, one of them might turn malignant and you can have all the neoplasms, right? So you can easily structure around them and you can use the individual diagnostic criteria for all of the above mentioned lesions here, and you can entirely write an essay question, right? It's just a way to write an essay question if at all you have an 25 mark question asked in your final exam, fine? That's about today's case. It's Hodgkin's lymphoma in a bladder, fine? So we shall read more about pathology for postgraduates, and you can follow me on the Unacademy app. And all the classes I mentioned are special classes which will be useful for you guys to approach a case. We are going system wise. We are done with endometrium cervix. We'll be done with ovary this month, and once FGT is over, we shall compile them and have a small test, fine? And all of them will be special classes. It will help you for sure. You can interact with me live in the classes. Let's see that we did create a few MCQs as well, targeting your NEET super specialty exam or your FRC path. We'll have more polls in future targeting for you guys. You'll have a notification coming, and all the classes will be in the evening, so that it'll be comfortable for you to finish your duty and come and listen. You can have the PDF downloaded after the class, and you can use your laptop or mobile or whatever it is, right? And if you miss it, you can have a recorded version as well, fine? So see you soon there in the Pathology for Postgraduate Lecture Unacademy. I'm excited for it. Hope you are too as well, fine? Thank you for your time. See you in another case. Till then, bye from Dr. Anjal. Bye-bye.